Hello, and welcome to tonight's program, Oh Say Can You See? Vision Care for Veteran Populations. My name is Rishi Singh. I'm chair and moderator of this program from the Cole Eye Institute in Cleveland Clinic, Cleveland, Ohio. And I'm joined by my esteemed faculty panel for today's program. First, Dr. Mansavi Kapadia. She's at University Hospital and also at the Veterans Eye Hospital in Cleveland, Ohio. Dr. Evelyn Lewis. She's from the Veterans Health and Wellness Foundation. Dr. Natalie Chung from the Lewis Stokes VA in Cleveland, Ohio, as well as assistant professor of ophthalmology at Case Western Reserve University. And Dr. David Roncone, he's at the Lewis Stokes VA in Cleveland, Ohio as well. Here are our financial disclosures for today's presentation. And we're going to be talking about these learning objectives tonight. Our veteran population is growing at a really exponential rate. They're seeking care both in our VA systems as well as outside our VA systems. And so this program is really to discuss some of the best practices about identifying veterans in our population, screening for eye conditions that relate to their specific populations, but also to sort of discuss some of the best evidence-based medicine practices for our patients in general. And we'll talk about managing veterans with eye diseases using the appropriate screening tools and technologies for both anterior segment and retinal diseases. Today's focus will be on anterior segment disorders, and it's my pleasure to have the speakers lead this program tonight. This is a joint accreditation activity provided by Advanced Knowledge in Healthcare, and you will receive CME credit at the end of this program. It's supported by an educational grant from Regeneron Pharmaceuticals. And after the program today, we'll send you an email on how you can claim your credit for today's program, both for the optometrists and for the ophthalmologists watching. You'll be able to obtain the credit needed, CE and CME credit for the program tonight. Please use the question box for the program. This is a live program, so feel free to ask questions of our speakers. We have a Q&A session at the end of the program today, which we'll be happy to take your questions and answer any of your queries at the end of the lectures. And so today we'll lead it off for the first presentation for tonight's program by Dr. David Roncone, who's going to talk about optometric screening of patients with dry eye and other anterior segment disorders. David?
Thank you, Dr. Singh. So I'm going to kick off the anterior segment module today with the Oh Say Can You See theme. And to start off, I just wanted to iterate the Department of Veterans Affairs. It's the world's largest healthcare system. It's the second largest U.S. federal department. We have our own budget, so the VA never shuts down in case the government goes on furlough status. We have about over 350,000 full-time employees. When you look at our population, we have about 19.5 million veterans throughout the world. And when you look at the divide among the various wars and peacetime, our highest amount is through the Gulf War at about 8 million, trickling down to the Vietnam era vets, to peacetime, to Korea, to about 300,000 World War II veterans left. When you divide our population by gender, 10% of veterans are female and about 90% are male. And when you take this roughly 9 million total veterans out of the 19.5 million that are coming into our facilities at the VA, it's about 47%. But this is a key number to remember, because when you take that 47% of veterans that are coming in our doors, about 80% of them report concomitant Medicare, Medicaid, TRICARE, or private insurance coverage, such as Anthem or Blue Cross or what have you. So some of these veterans you'll be examining, and you really won't even know they're a veteran unless they inform you or you ask them. And I think that is a key point to remember, that veterans receive medications at a reduced cost at the VA. So we welcome you referring your patients to our facility so that they can obtain services that they well deserve. When you look at the definition of a veteran, it's individuals who've served in one of 7 uniformed services I think when I date myself with some of the commercials, the Army, Navy, Air Force, Marine commercial from 25 years ago, but we do forget that there are other populations that encompass veterans. Basically, any veteran also has to have a honorable discharge to be classified as one. And when you look at the 7 uniformed services that make up veterans, they are obviously, we said Army, Navy, Air Force, Marines, but the Coast Guard also is a uniformed service. Public Health Service Corps are, and also Commissioned Officer Corps in the National Oceanic and Atmospheric Administration. The federal government also just, classifies other groups that range from National Guardsmen to Department of Defense personnel, to even World War II merchant marines that protected ships and sent supplies over the oceans to our servicemen and women. Philippine Armed Services include that, and some eligible survivors and dependents of veterans also classify receiving veteran service. When you look at the basic screening for all eye disorders, it's no different what we do compared to what you do. It's pretty much all the same. But I'm going to highlight 4 major areas of the basic exam: patient history, slit lamp exam, glare testing, and interferometry and potential acuity meters in this lecture today. 2 other points that I do want to bring up of how we screen our patients at the VA. All new patients have an FDT screener. That's really nice to have because number one, you never know if you're going to pick up a hemionopic defect in a 70-year-old patient. And number 2, you never know when you have a patient that's going to develop a pale nerve later on in your timeline of examining the patient. So we like having these on file for us. They come in really, really handy. Crucial ancillary testing, or glare testing and interferometry. And I'm really big on glare testing because I practiced at a cataract and LASIK referral center for about 8 years. And our results hinged upon knowing if a patient was a better LASIK candidate or a better lensectomy or cataract surgery patient at that. And so I glare test all my patients that I see in a chart that have a 2+ cataract. I glare test all patients, usually around the age of 60 or older, just to have a baseline in the system. And I'm not saying that you have to do that, but based off the ARIDS and Blue Mountain study, these are high-risk patients for you to consider glare testing in your practice. Number 1, based off ARIDS, are those over the age of 60. Females are at higher risk for cataracts. Any patient with any type of hormonal replacement like estrogen is at higher risk. Patients with increased BMI or low body weight. Patients of lower socioeconomic status. Ethnicity didn't play a huge role, just non-Caucasians by a mild amount, with the cataract cortical risk being higher. Myopes, those were at higher risk for cataracts. And last but not least, smokers and diabetics were usually manifesting cortical cataracts at a higher rate. I love interferometry. When I have that patient that's 20/30, 20/40, I like using it to see, if that cataract that I see gives the patient a better prognosis for having surgery. It's a real nice instrument to have in your office also, because you can deduce whether the macular degeneration or the cataract is really the result of the decreased vision. And last but not least, your dry eye syndromes. In the wintertime in Ohio, when we have our heat on, our patients seem to lose like a line of vision just because their eyes seem to dry out. That's not an uncommon thing. And interferometry is great to see if the patient can improve their vision there too to 20/25. So let's stick with cataracts first. I talked about that a little bit in the previous slide. When you look at the 5-year incidence based on the Blue Mountain study, it was pretty low, between 0.3 and 1.7% up to the age of 65. But once you reach over 65 years of age, it jumps to 7.9%. And again, 75-year-olds to 17.5%. So this 5-year incidence really drives home the point of the importance of glare testing in these populations, because as we age, with different conditions, medications, and more exposure to sunlight, our risk increases for cataract. And when you break those patients down I mean, you look at the incidence by type, nuclear is definitely our most common type at almost 18%, with females manifesting nuclear at a higher likelihood than other patients based in the Beaver Dam study. This is when you look at prevalence of cataracts, a non-veteran versus a veteran, it wasn't an apples to apples comparison in the NIH study and Sadie's study out of the Capitol Hill VA near Washington, D.C. But basically, non-veterans age 40 or greater had a prevalence of about 17%, with Caucasian Americans at a little bit higher of a prevalence than African Americans. When you looked at that veteran patient with 20 years above the non-veterans at 60 years of age, the prevalence was about 12%. And it's interesting in that study, the patients who made it up followed the identical amount of female to male split in the veteran population, which was 90% male, 10% female. In this veteran study that Sadie conducted, when you looked at ethnicity, it wasn't equal 50-50, but the patient base was 70% Caucasian and 30% African American. When we look at patient medical history, this was another point on the general eye exam, our basic screening at looking at these patients. Two key things that you want to look for when you're looking over a patient's medical history that we do at the VA is, number one, did they have a traumatic brain injury? And number two, do they have any type of mental health disorder? And the reason for that is because both conditions are associated with ocular trauma. And with ocular trauma, we can see sequela. And those sequela, when we refer patients out to cataract surgeons, they need to know what they are so that they can modify their surgical technique or decide on how they're going to pursue surgery if they run into any glitches during the procedure. Mental health disorders, again, those patients have an association with dry eye syndrome. And dry eye syndrome can definitely affect our cataract surgeons' posterior chamber IOL power calculations. And Dr. Chern's going to graciously review those on part of her lecture later. So when you look at trauma in general, Walter Reed Medical Center sees the vast majority of trauma. At the VA, we're seeing the patients after the trauma has occurred and when the patient's in typically veteran status. But when you look at a civilian versus active duty split, it's roughly the same with an incidence of about 0.3 and 1% with the difference. But when you look at what's different or similar, what I should say is similar between these populations is the younger patients seem to manifest trauma more than older ones. In civilians, you're at a 2.5 times risk in your 40s compared to a 75-year-old, whereas you're at a 6 times risk in active duty personnel at the age of 17 to 24 to have trauma compared to a 40-some to 65-year-old patient. When you look at gender, males were always more at risk for trauma. When you look at occupation, blue-collar workers were always at more risk for trauma. Even in active duty, the desk workers, obviously, it was less common at this juncture in these types of wars that you would have a blast injury to the facility you worked in rather than a military personnel like a troop on the ground. Interestingly, when you look at civilian populations, the most common traumas are due to sharp objects. I found this one study, it was interesting to read that the number one or one of the top reasons to have a trauma in the country of Belgium was from a champagne cork popping. So that was kind of interesting to hear. When you look at our active duty personnel, it's a whole different story though. TBI, blast injuries can cause them, but also even just motor vehicle accidents and fist fights. And when you looked at those that were in car accidents and got into a fisticuff, 85% of them had an orbital blowout fraction, a contusion, or an ocular adnexal laceration. So when we move on from this topic of trauma and we look at these active duty patients with history of TBI, blast-induced TBIs manifest very similar ocular findings as any civilian that had a motor vehicle accident, any civilian that's had a fist fight, or any military personnel that was in those types of situations. When you look at a study that looked at 46 combat veterans during their Iran and Afghan wars. When these patients were looked at 2 weeks to 7 years after injury with an average of about 5 months, 43% of them had an internal eye injury no matter the level of the TBI. So the conclusion to this study really is that we really need to do general eye exams on TBI patients. And those statistics are all based out of the Cockerham study. When you look at the actual location of trauma, posterior segment trauma, the vitreous, retina, et cetera, yielded a prevalence of about 28% of ocular sequela, whereas 50% ocular trauma findings were found in the anterior segment, with almost an equal prevalence between angle iris and lens versus the ocular surface, the conjunctiva and cornea. When you take these blast-induced TBI sequela and these active duty personnel, when you look at the conj and corneal findings, 22% of those veterans had a corneal scar or foreign body, whereas the angle iris and lens findings, 27% had angle recession, 13% had traumatic mydriasis or an irregular pupil. So when looking at that, no matter what type of trauma you have, no matter what type of patient you have, veteran or non-veteran, it's very, very important to do a thorough slit lamp exam. And you have to decide if you want to see if you yield that 27% likelihood in gonioscopy in these traumatic populations. At the VA, even if I conduct gonioscopy and I code for it, it's not like the patient's going to be getting charged for the gonioscopy. So it's a little bit different for you in the private sector when you code for this, because I imagine if you find no finding, then you technically can't bill the procedure. So looking at slit lamp and gonio on these patients, these iris and angle abnormalities, you think of doing gonio on active duty military. You want to do your thorough slit lamp on these active duty military patients. All of my uncles fought Golden Gloves. That's a really common thing, 50 to 70 years of age. You want to ask them if they boxed in the military, Golden Gloves, were they a boxer? You'd be surprised at the number of people who have. Any patient that's elderly, that fell, that had an orbital contusion, patients that have strokes where they fell down, they have a black eye, and they say, I don't know what happened. They just found me laying there with my black eye. Those are the types of patients you really need to look for the irregular pupil. So in your slit lamp exam, you want to look for an irregular pupil. You want to look for iris sphincter tears, such as in this picture where the red arrow is. You can see a notch of the iris. But you can also see that the iris crypt detail at this arrow at around 11 o'clock, you don't have real fine iris detail in that area. But if you look down on the opposite quadrant, like around between 4 o'clock and 6 o'clock, you can see those delineations better. And that's a real easy way to find a sphincter tear. We will always want to look for iridodenesis and phacodenesis in these patients. Any wobbly iris or wobbly lens when we look inside, our surgeons need to be aware of those because that can alter how they conduct their surgical plans. And last but not least, in gonioscopy, we hone this, or we emphasize this with our externs and residents, that sometimes the normal eye tells you more than the abnormal eye. So when you see a patient with a monocular sphincter tear and you do gonioscopy on them, the ciliary body is always going to be a little wider, like you notice on the right side of the picture. And you can also see it's almost like a white-gray thready appearance posterior to the ciliary body. And usually that's prominent for iridodialysis, where you see a pulling of the iris away from the anterior chamber structures there. So we always want to look for those when you do conduct your gonioscopy, because treating glaucoma before a patient has surgery is important, and diagnosing glaucoma is important too, and deducing whether recession is present is very important, because that may play a role into whether your surgeon uses a MIG or not. And Dr. Kapadia is going to be discussing MIGs a little bit later in this lecture. Another key point, we talked about injuries, TBIs. We're going to talk a little bit about mental health disorders. There's 4 major types: mood disorders, psychotic disorders, PTSD, And last but not least, substance abuse disorders. That's one that not a lot of people think about. And when you look at studies done, some studies include that in when they're calculating prevalence and some don't. So that can actually fluctuate the numbers some. When I see patients rolling into our practice at the VA, I'm able to have a really nice list of medications in their patient medical history. So it's really, really easy for me to look. And we have 3 different studies that looked at non-veterans, active duty, and veterans. And as you can see in yellow at the top, the prevalence of mental health disorders was about 26% in veterans, followed by 20% in non-veterans, followed by 8% in the active duty patients, with those serving in the Army having the highest prevalence. When you looked at the veteran population, patients with depression had the highest prevalence, while serious mental illness patients had a lower prevalence. And those would include psychoses and schizophrenia and what have you. Across the board, when you look at the prevalence, even though veterans yield the higher prevalence rate, they kind of all follow suit. And what I mean by that is for all populations, females have a higher prevalence. As you can see in the non-veteran population, it was 24% for females versus males at 16%. When you look at all 3 populations, younger patients had a higher prevalence. Under the non-veteran population, again on the left side, those patients 18 to 29 were about 30%, where the other age brackets decreased in prevalence. Lower pay grade, those patients had a higher prevalence of mental health disease. And then last but not least, when you look at ethnicity, patients who had 2 races had a higher likelihood of having mental health disease compared to Caucasian patients and then Asian patients. Big risk factors for predisposing veterans with mental illness to having an ocular disease when you do the exam would be cigarette smoking, which you deduce in your social history, metabolic syndrome, which includes diabetes, and then antipsychotic medications. When you look at ocular findings in the non-veteran population, so patients that are pretty much rolling into your practice, when you look at the division of normals versus schizophrenics versus bipolar versus major depressive patients, the prevalence is pretty low when you look across the board. But the one that jumps out the most is dry eye. And so the remainder of my lecture is probably going to be focusing more on dry eye here. And we're going to really hone in on the DEWS-2 study. These DEWS studies are really long and they have about 1,000 sources cited in them. So I cleaned the things out or weaned the things out of that study that I wanted to share with you that I think about when treating and managing dry eye, especially before I get my patient in the hands of the cataract surgeons. When you look at a study done by Sadie, so this is still Sadie, out of that Washington, D.C. area VA hospital, serious mental illness. In the previous slide, we said it was really low prevalence-wise, right? It was about like 3%, but I wanted to just iterate a couple points here. That study looked at VA patients with serious mental illness, and they had 6,000 patients in that cohort there. The second cohort was VA patients without serious mental illness, which almost tipped like 140,000. Cataract patients had a higher prevalence with serious mental illness. The glaucoma patients had a higher prevalence with mental illness. And the dry eye syndrome patients had a higher prevalence with mental illness. So let's hone in on dry eye and really talk about it in depth. It's multifactorial. It's accompanied by ocular symptoms. That's part of the definition now. Personally, I still leave dry eye syndrome as a diagnosis, but I'll list asymptomatic in my parentheses next to it. But when you look at dry eye, you have tear film instability, hyperosmolarity, inflammation, there's ocular surface damage. When you look at the market for this, there's millions of dollars spent on it. And a lot of our veterans like coming to us because they get these medications for free, which is nice. And the ones that do pay for it, they don't pay too much money for the ocular lubricants, if you'd say. And even at that, same with the recyclosporin and the lifitegrast. When you look at Beaver Dam, the incidence was 13% over 5 years in a Caucasian population, about 50 to 90. And as you see, as you age, the incidence almost doubled, with females having the higher incidence than males at 25 versus 17%. This is great, this prevalence. Non-veterans in the DEWs versus the Galore-Fuhr study out of the Miami VA, Bascom Palmer, and Mass Eye and Ear, they had the identical age group, 50 years of age. And veterans at 24% were 10% higher to have dry eye syndrome than a non-veteran. And as you can see with the statistics again, females outweighed males. And in the non-veteran population, Asians outweighed African Americans and Caucasians, while in the veteran population, the ethnic background difference was a little bit higher for African Americans to yield dry eye over a Caucasian patient. So dry eye, we use multiple screening tools for it. It's really, really important. The reason we do, such as glare testing and interferometry, is because we need to make sure the patient has dry eye. We need to utilize our surgeons' chair time to keep economies of scale flowing through the practice and great profit maximization. But those aren't the only reasons. We need to deduce factors contributing to it because it's multifactorial. So we really have to think of how we're going to proceed the therapy with our diagnosis. We need to really hone in on what layers are affected and what the best treatments are for our patients. And in the end, when you do this, and I do it, our patients are usually pretty darn happy at the VA because we yield some awesome cataract results with our awesome surgeons that we have. So let's talk DEWs. DEWs, multiple tool screening. They looked at triaging, risk factors, diagnostic tests, and subtype classification. And when we're triaging patients, we're going to start out there, the first step. We do that by patient history, asking patients how much water do they drink? Do they smoke? Are they diabetic? Those types of things. Where they live at. But another key point are these dry eye questionnaires. And in DEWs listed a lot of them. And the one that we don't run into too often is, what would you say, in triaging is we don't have to use these a lot at the VA because we're not dealing with private sector insurance like you are. So like when a veteran has dual care and let's say they are seen at Aetna and they come to the VA, sometimes depending on the veteran's classification and boarding into the system, they have to get approval from their private sector insurance first. And then when the private sector insurance negates the medication, they'll get it through the VA for free. So I don't have to use these a lot because I already know I can prescribe it and get approval for the veteran. But some of those patients that have that dual care, I do have to fill out a dry eye questionnaire 5, and I have to make sure that their score is greater than 6. And so ocular surface disease index is another great type of questionnaire that can be used. I really like this DEQ5 because look how simple it is here. It's 3 basic areas. It's easy to fill. It's easy to find out your answers, and you can move on. When you look after triaging questions, then you have to look at everything that you've asked and look at your dry eye questionnaire, and you got to really analyze your data. So you're analyzing your histories, your medications, your social history, and your questionnaires. And in DEWs, they looked at risk factors for dry eye. So this risk factor analysis is key. And when they looked over risk factors, they labeled them as consistent, probable, and inclusive, and non-modifiable and modifiable categories also. We're going to pretty much talk about the consistent ones today. So when you look at consistent risk factors and you look at DEWs 2, female gender had a high prevalence. And actually, when you looked at the Galore study again out of Miami, Bascom Palmer, and Mass Eye and Ear, females were 2.5 times the risk to have dry eye than a male. When you look at age, patients over the age of 50. When you go to 60 years of age, You increase 1 time a decade, 70, then you're up to 2, 80, you're up to 3 times the risk for having dry eye. So age is a really big risk factor. Meibomian gland dysfunction, when your meibomian glands aren't excreting good oils, it can lead to evaporative dry eye. Stem cell transplants related to lacrimal gland destruction and aqueous dry eye. Any patient that's concentrating. Here they list computer use. I add truck drivers. Doesn't matter if you're staring at road signs and not blinking and you have a low blink rate, or if you're looking at a computer all day long, you're going to have evaporative dry eye. Asian race was a risk factor with 1.5 to 2 times more than Caucasians. Contact lens wear was 4 times. Sjogren's, we all know that's a risk factor. Environmental conditions, with the top states with these types of environmental conditions listed. Air pollution, California and Pennsylvania, that's a risk factor. Excessive wind in Nebraska, that's a risk factor. Low humidity out of Arizona and high altitude at Colorado are risk factors. But another key risk factor is medications. And medications can be up to 2 times depending on the med. And interestingly, 2 of our populations we talked about in our patient medical history during our screening, TBI patients, mental health disorder patients, some of those medicines can be related to dry eye. So let's look at them. Antipsychotic medications, they decrease aqueous production. Sumatriptan, we use those in migraine patients and in TBI-related headaches. Does it really cause dry eye? It's skeptical, but if you go into the FDA website and you look up all 4 laser platforms for refractive surgery, they'll list corneal opacity in dogs as a side effect. And so some skeptics say that it might cause dryness. And that's actually listed as a warning before doing surgery. It's not a contraindication, but a warning to let you know that you have to think about whether you want to perform surgery on a patient that's on sumatriptan. Antihistamines affect mucin and aqueous. Beta blockers affect aqueous. Diuretics affect aqueous. So do birth control pills. And last but not least, isoretinoin, that's a sebaceous gland inhibitor. And we all know our meibomian glands act in that same way. So it can really destroy your lipid layer to your tears. So all of these medications are risk factors for dry eye. And we really need to look at our patients' meds lists. Moving on, we're going to keep talking about diagnostic tests now. Slit lamp exam. It's really important. Deuce says you have to roll out dry eye mimickers and complicators. A mimicker is a patient that has a normal tear breakup time of 10 seconds or more, or a tear meniscus of about 0.2 millimeters or more. But the patients are still complaining of dry eye symptoms, burning, itching, watering. And then to roll out complicators, a complicator is a patient that has a fast tear breakup time, has a small tear meniscus, and their dry eye is complicated or exacerbated by another condition, such as concretion cysts or a patient using a CPAP. So when we do slit lamp exam, not only are we looking at the ocular surface, but we're really honing in on the tear film and we're assessing it with tear breakup times, osmolarity, and ocular surface staining. When you look at mimickers and complicators, we can think about symptomology, medical history, external exam, and slit lamp exam. Patients that complain of monocular epiphora, we think about pressing on the puncta to see if there's fluorescein regurgitation, or we can dilate and irrigate these patients with monocular epiphora. Because in those cases, we're thinking about nasolacrimal duct obstruction, not dry eye syndrome. Patients with obstructive sleep apnea, COPD, this air might be blowing on their eyes. If they have a normal T-butt and a normal tear meniscus, they don't have dry eye. They just have ocular surface drying from their environment. External exam, we really need to hone in on the eyelids, look for BV telangiectasia, the lids. But we also, on external exam, we need to sit back and look at the patient for rhinophyma, facial telangiectasia. Those types of situations usually lead to eyelid signs, which contribute to a dry eye syndrome. And then last but not least, our slit lamp exam, we're looking at the lids, conch, and cornea. When we think of these mimickers, like nasolacrimal duct obstruction, eyelid cysts causing foreign body sensation, MGD and rosacea, even ectropion, entropion, trichiasis, stenosis, GPC, and floppy eyelid syndrome. Those types of conditions are either mimicking the symptoms in a normal patient with a normal tear film, or they're complicating the dry eye through the symptomatic presentations that your patients complain of. Another key one I often see, just because, the saying that we see elderly patients at the VA, I really don't think we do. We're starting to see younger ones flow through. And as you can see in the earlier slides when we talked about population, our Afghan and Iraqi war vets, we're seeing them in higher numbers now. But in the elderly patients, that some of them do have chalasis and it covers the puncta, and they'll manifest watering of the eye. So those types of patients, they have a normal tear film. We refer those to our surgeons, and then they can decide if they want to take a liberal approach with the patient and use lubricants, or if conjunctival removal is prudent. Last but not least, you have this pinguecula, pterygium, scars, EBMD. Those can all cause burning, itching, watering with the patient blinking over an irregular surface. So those either can mimic the symptoms again, or they can complicate or exacerbate the dry eye. So when you look at tear film tests, at the VA, we use fluorescein, which is the invasive type of test. Non-invasive tests that we don't conduct at our facility are like interferometry and high-speed video keratoscopy. But fluorescein T-but's just fine. I think we get what we need out of that test, including looking at the tear meniscus. We don't conduct any osmolarity testing, but basically patients with greater than 308 are considered dry eye patients, whereas those with 290 milliosmoles or lower are normal. The test is actually pretty a fast test. It only takes 10 seconds to do. It would be just something you have to decide if you want to invest on it in your practice. Last but not least, the third part of looking at the tear film's ocular surface staining. And so we use fluorescein to stain cells and look at compromised integrity. We use lissamine green to stain cells, especially the damaged cell membranes. We don't use a lot of rose bengal because, it stings a lot for patients. But when you look at some of these insurance panels, again, they want you to have 5 spots on the cornea or 9 spots on the conj staining documented before they approve, like a cyclosporin or a lifitegrast. But even though, I do want to bring up this point that many years ago, Don Korb came up with this lid wiper epitheliopathy. And some people feel it is related to dry eye, and some people feel it's just not even related to it. But basically, if you look on picture A, up on the top portion of the green lissamine staining, you'll see a real fine pencil thin line. That's called the Marks line. That's present on the upper eyelid and the lower eyelid. The original lid wiper that Korb talked about was all upper eyelid because it was like a windshield wiper coming down. But as we know, when we blink, our inferior eyelid does increase a little bit. So when I look at lids and I stain with lissamine, I look at uppers and lowers concomitantly. But basically, in a normal patient, all you should see is that thin line. If you see more than that, that's what lid wiper is. And our eyelid, when you look at it, canthus to canthus, is about 20 millimeters in length. And so as you can see, you can grade it on a scale based off a length of 0, 1, 2, or 3. In patients that have 10 millimeters or more, which is half the eyelid length, that's considered severe lid wiper. And you also look at the sagittal width, which is pretty much the height of it. And that lid wiper area extends, you can only see it when you flip the lid. It extends to where about like the pink hyperemic area is in picture A, which is about, if you're looking at it, it'd probably be about like a ½ inch inferior to the Marks line. And when you look at that, if 75% of that distance shows staining, then you know that the patient's in a severe level of lid wiper. So again, I look at the lid staining in this area because it's telling me if the keratinized and non-keratinized area of the eyelid and conj, if it's healthy. Because if there's a lot of staining, that area of the lid wiper houses goblet cells. And as we know, goblet cells help promote the mucin layer of your tear, just as much as goblet cells of the bulbar conjunctiva do. And those types of staining patterns, whether it's on the bulbar conj or on the lid wiper area, that clues me in that cyclosporin and lifitegrast are great treatments for these patients, because both, most specifically cyclosporin in early studies, increased bulbar goblet cells by 198% in non-Sjogren's patients. So by bumping up your goblet cells, you increase your mucus layer of your tear, and your patients are more comfortable. Moving on, the last classification, it's we're looking at subtypes, and basically we're trying to hone in to decide if it's evaporative related to your meibomian glands or if it's aqueous. For looking at evaporative, not only are we looking at meibomian glands, but we're pushing on the lids to see if there's a turbid expression. When you look at imaging, some people in practices have really extensive imaging, or they'll use their spectralis to look at the zebra stripes of the glands, where you'll see dark and hypo and hyper pigmentation. But there's a real cheap way to do this. You leave your slit lamp, you place the patient in your slit lamp, you turn the light off, you take your transilluminator, you press it on the eyelid and kind of like avert it, and you can look for the zebra stripe appearance to see if you have meibomian gland dropout in areas. And that can help you deduce whether you do have an evaporative dry eye concomitantly with aqueous deficiency. When you look at tear volume tests, I don't do a lot of them unless the patient has Sjogren's. I don't do the Schirmers. I pretty much just stick to tear meniscus, and I use like a 0.1 millimeter beam, and I determine if I have about the 0.2 millimeters, that's the norm. Pushing on the eyelids, this would be like a turbid expression of your meibomian glands. You can kind of see the thickness there. So in the end, after we look at history, after we do glare testing and interferometry to see if what we have going on with our patients, is it dry eye, is it cataract, what's going on with our patient, we need to develop a state of homeostasis, and that's real important. We need to improve the osmolarity and cut down on inflammation, because when you do refer this patient out for cataract surgery, we want the tear film nice and stable. And so in treating them, DEWS has 4 major steps: 1, 2, 3, and 4. If you look this up, 1, 2, those have the highest number of things to do, or what would you say, options to treat your patients. So step 1 is patient education. We look at modifications, environment. Example, CPAP patient. The patient has benign hyperplastic prostate, because I see a lot of males at the VA. I'm putting them on the gel, like a carboxymethylcellulose 1% gel. Why? Because they're getting up in the middle of the night a lot to go to the bathroom, and they don't like the ointment. If they don't have a hyperplastic prostate, I'm placing them on like an ointment at night to keep their eyes moist, because the air is leaking on them. Modifications, medications. We can change glaucoma meds to preservative-free. Another modification, increase your water consumption. Females should drink 8 12-ounce cups a day. Males should drink 10. Diet, omegas, do they work? I'm kind of split between this. I've tried them before, and they made me, what would you say, more comfortable wearing my contacts, but there's always the placebo effect. In the DREAM study, interestingly, when they had patients using omega-3, they chose olive oil as their, what would you say, their control, I guess, if you'd say. And olive oil has omega-3 and 6 in it. So did the DREAM study really show that fish oil, et cetera, can help a patient with dry eye? I think that's still to be determined, and I think everyone has an opinion on it. Again, in step 1, we're grabbing for the preserved lubricants first. Why? Because the evidence-based studies show that it increases tear thickness and retention. It reduces friction of the bulbar conj, which increases goblet cell density, and it protects the surface. At the VA, we use polyvinyl alcohol-based tears in mild cases. We use carboxymethylcellulose-based, like 0.5% in mild to moderate cases. And then last but not least, in step 1, we pursue lid scrubs and warm compresses. In step 2, we reach for the artificial tears that are unpreserved. At the VA, we also have tea tree oil in our formulary, so we can use that to utilize on patients for lid scrubs or Demodex in and of itself. We punctally occlude. We do in-office treatments. We don't do heat because it takes about 10 to 15 minutes to 12 minutes because it can utilize all our resources. But we do remove biofilm and collarettes, and it only takes 5 minutes to do that procedure. We kind of have like an electric toothbrush-like instrument, and it's patented and what have you, and it's approved by the FDA and what have you. But the bristle on it spins in a rotary direction, and we can clean the lids off, and it works really, really nice. We use combo meds and blepharitis. I love using soft steroids like fluorometholone. I'll prescribe like a 5 milliliter bottle and tell a patient to use it twice a day while I have them on an immunomodulatory or a lymphocyte function associated antigen inhibitor. That way, they're getting comfort for the month or two that they're on the steroid, while the immunomodulators increase in their efficacy over the 3 to 6 month time period. Because sometimes it takes a little bit longer for those types of agents to work. Again, our patients get these medications really, really at a low cost, so they love it compared to like a brand name medicine in the private sector. One last thing I want to make note of, macrolides. The anti-infection dosage of it, between 50 and 100. We have approval from our pharmacy to use it at 20 to 40 milligrams a day, which is really, really nice. And I like that for 2 reasons. Number 1, I don't need to go to a higher dose. Number 2, I can use it once a day. And last but not least, number 3, I think that there's a lower risk of patients having GI upset at such a low dose. One thing I do want to make a point of to everyone is when you're using like a doxycycline and these macrolides, specifically doxy, you have to be real careful and continue to dilate your patient and look at the optic nerves, because one of the side effects with it is optic disc edema. So you still have to look at the nerves if you're leaving a patient on it long term. Step 3, we look at oral secretagogues, which we don't use at the VA much. Autologous and umbilical cord serum, we don't use. Bandage lenses and semisclerals, we do. And when you look at umbilical cord serum and autologous serum, I do want to make the point of this, if you're using them, that the autologous is derived from blood, where umbilical comes from the umbilical cord. But those growth factors, they're almost the same in each. The umbilical cord has neural growth factor, where autologous has hepatic and platelet derived. But the catch with umbilical cord is some people are a little bit frightened of it because of risks, because it's coming from, another entity, a newborn umbilical cord. So some are a little afraid of, can you transmit any type of bloodborne pathogen? Last but not least, step 4, long-term topical corticosteroids. Most aim for soft steroids. I don't like leaving patients on steroids really, really long-term like that. At the VA, we do surgical punctal occlusion with heat. We do use amniotic membranes. And we do use tarsorrhaphy too. Our surgeons do those for patients with exposure. And when you look at these membranes, dry amniotic membranes I use at the VA. They're less expensive. They don't take up a lot of space. It's about the size of a DVD case, if you still buy those. They store easy. They're comfortable. Once I reach the point to where I feel a patient needs a cryopreserved, I got a heck of a cornea specialist down the hall from me, Dr. Churn. I'm sending the patient to her. She's going to evaluate it and decide if she wants to use a cryopreserved membrane or if she wants to pursue other treatments. And the ones she uses are FDA approved, and they just have great innate characteristics because it maintains most of the natural amnion, which contain growth factors. So in summing things up today, we all treat dry eye differently. And there's a scope study that looked at global trends. And when you looked at United States versus those outside our borders, we do it a little differently. We're both aiming for lubricants, as you can see on the left side of the screen. In the US, we aim for cyclosporin as our second treatment. while in the non-US countries, they're aiming for a scleral lens next. Our third route's steroids. Theirs is punctal occlusion. And their fourth route's autologous serum, where ours is not. When you look at hospital versus community, down the board, when you look at the right side of the screen, it's pretty much the same. They're all doing it the same, whether someone's in a private practice or if they're in a hospital. So let's just make some broad conclusions here before I turn things over to Dr. Chern and then Dr. Kapadia. Number one, non-veterans and veterans have similar prevalence of cataract. Number two, veterans and non-veterans differ in their prevalence of dry eye. Number three, you have to consider rolling out angle recession in a veteran or a non-veteran TBI patient, because as we said before, 40% suffer some type of intraocular trauma. Four, you need to analyze the tear film very, very carefully. And it doesn't matter if it's a veteran or a non-veteran, because in these mental health disorders, especially with medications used, they run a higher prevalence. And number five, remember, dry eye is symptomatic. It's multifactorial. So we really need to use the DO study as a nice basis of evidence-based medicine to examine our patients. Look for the mimickers, the exacerbators, make sure it's dry eye. Stabilize your tear film before you send it to your cataract surgeon. Make sure it's cataract that's the etiology of the decreased vision. Because in Ohio, with dryness, especially in winter, sometimes it's really dry eye that's the etiology for decreased vision. And then last but not least, with a stable tear film, the patients will be extremely happy after cataract surgery because the PCIOL calculations that are conducted by the surgeons to measure axial length are usually spot on. So thanks so much. I'm going to turn things over to Dr. Chern right now, and she's going to take over the screen.
Thank you. And before we get to Dr. Chern, I just want to remind everyone to keep submitting questions. We're getting some really great questions from all of you watching. I appreciate the talk, Dr. Roncone. And Dr. Chern, you can take it on from here.
Hi, everybody. I'm Natalie Chern. I currently work at the Lowest Oaks VA Medical Center, and I'm also the cornea specialist there. Today I'm going to talk about corneal considerations in cataract surgery, specifically dry eye syndrome, EBMD, Fuchs, pterygium, keratoconus, refractive surgery, and contact lens use. I'm going to throw in a few sort of cases that we recently saw and how we treated them as well, just to keep things interesting. So first thing, great segue. Dr. Roncone did such a good job at sort of describing dry eye and how we treat it and how this affects us in cataract surgery. Of course, dry eye and blepharitis go hand in hand, can contribute significantly to glare, halos, fluctuation in vision. And this, we sort of have to grade and sort of look at, and also look at the cataract to see, what the patient's complaining about more. Is it the cataract or is it the dry eye? The biggest issue with dry eye and cataract surgery is that it affects the keratometry readings. And in our experience, it could be a little bit of dry eye or a lot of dry eye. It's such a big spectrum, and it can affect the keratometry readings really quite a bit. Of course, dry eye and blepharitis also increases risk of infection after cataract surgery, so it's really important to treat and optimize this. And then if you do cataract surgery and never treat the dry eye, not only could your cataract sort of surgery aims be off in terms of the implant selection, but the patients may not be happy after cataract surgery because they still continue to complain about glares and halos and fluctuations in vision. So it's really important to treat this prior to cataract surgery. And of course, topical NSAIDs is something that we typically use in cataract surgery to prevent and treat cystoid macular edema, and dry eye can limit our use of these medications as well. So lots of important reasons to treat dry eye prior to cataract surgery. So this is one case. This is an optical biometry. This is a lens star in a patient that came in with both dry eyes and cataract. And in terms of our calculations, most important things that we're looking at, axial length and keratometry readings, are two big factors in calculating our implant. But also, of course, our newer formulas also include anterior chamber depth, lens thickness, white to white, to estimate the appropriate lens position. But here you can see axial length, both right eye and left eye are pretty symmetric, around 25.3. But when you look at the keratometry, right eye, you can see it's about 42, 43, and in the left eye, 43, 44. And so when you look at the implant calculations, when we're aiming for distance vision, the right eye, we might be choosing a implant power of 17. It's in the back calculation. And in the left eye, you're like, okay, well, it's 15.5. It's really different. And it's really different because the keratometry readings are very asymmetric. So this patient wasn't optimized for cataract surgery yet. The right thing to do is to sort of optimize him for dry eye, have him come back and repeat the calculation. This is what we did for him. And so here, this is pre-optimization, the right eye. Prior to that, the Ks were 42, 43. And then after optimization, it was more symmetric to the left eye, 43, 44. And so really the right implant power for him wasn't a 17. It really was a 15.5, very symmetric to the other eye. And so had we done cataract surgery without optimizing his dry eye, our aims could have been significantly off. So treatment for dry eyes and blepharitis, like Dr. Roncone talked about, we have various things. And again, just very important to optimize them. Of course, if we're starting them on things like Restasis or Xiidra, we really don't try to bring them back until 6 to 8 weeks until we sort of see an effect of those medications. And then try it again. And of course, it's especially important if they're a toric candidate or other, candidates for other specialty lenses to get the dry eye under control. So we're going to move on and talking about epithelial basement membrane dystrophy. And this can also contribute to significant decrease in vision, irregular astigmatism, glare, and halos. Again, really important to document where the map lines are. Are they central? Are they peripheral? How much of it is there? How much cataract is there? Is the patient complaining more of EBMD or more of the cataract or both? And if it is both, and sometimes EBMD is difficult to discern at the slit lamp, using fluorescein to sort of define where they are can be really helpful. If it's in the visual axis though, we really have to think about sort of getting topography or tomography and looking to see how visually significant this is. And if we do feel like this is fairly significant and in the visual axis, then consider doing epithelial debridement first, and then repeating the calculations 2 to 3 months after the cornea has stabilized is sort of the right thing to do prior to cataract surgery. Again, you could ask me, why not just do the cataract surgeries first, see how they do, and then do the debridement if the patient's not happy with their vision? And the answer really is, it's difficult because once you do the epi-debridement, again, it can affect the keratometry readings, which would affect the IOL calculations that you put in the implant in the eye. And that implant now is sort of secured in the eye. You don't want to do an implant exchange. And then the patient might not end up with sort of the aim that you originally intended. So we'll move on to Fuchs endothelial corneal dystrophy. And this, of course, can also contribute to decreased vision, glare, and halos. It's really important not to quantify sort of the grading of the Fuchs, looking at how thick the cornea is. Are there any defaults? Are there any haze that set into place? And also look at the guttae centrally and peripherally. Grading of the cataract is always very important. And then just to sort of, again, look to see, is the patient complaining more of Fuchs and more of cataract, or both? In any Fuchs patient that's undergoing cataract surgery, there's an increased risk of prolonged visual recovery and persistent corneal edema. When we think about doing staged versus combined procedures, meaning either cataract first and then transplant, or both together, if they already have pre-existing corneal edema or pachymetry greater than 640, that probably pushes us to do more of a combined procedure than a staged procedure. Types of keratoplasty. So typically most cornea surgeons are doing either a DSEC or a DMEC for a Fuchs. And just as a comparison, DSEC, the incision is typically a little bit larger than DMEC. The hyperopic shift, because the DSEC graft is a little bit thicker than the DMEC graft, is about is a little bit more. And so what we do when we do cataract surgery, we purposefully aim a -1 to account for the thickness of the graft. DSECs tend to be a more straightforward surgery, and it can be done in patients that have tube shunts or prior vitrectomy in more complex cases. In both cases, visual recovery is about 2 to 3 months after the procedure. In DMEC, there's less of a hyperopic shift. So for our aims for cataract surgery is a little bit less, maybe minus a half. There's a higher chance of graft detachment and rebubbling. There's a longer supine positioning. So if the patient can't lay flat for longer than a few days because they have significant back pain or COPD or obesity, then that's probably not a great procedure to do for them. But there is a little bit of a higher chance of getting to 20/20 vision. And so for people that have visual potential of getting to 20/20 and not having significant glaucoma or macular degeneration or other diseases that could limit their vision, DMEC might be a good option for them. So the newest thing that's sort of coming down is especially for more mild to moderate Fuchs that only have central confluent guttae that are very symptomatic, is this procedure called Descemet stripping only. So you strip the center 4 millimeter of the cornea, the Descemets, and you don't put a transplant in. This can be performed with and without cataract surgery. Again, it's still in the early phases. There are some case reports. People are still studying this. Initially, there can be significant worsening of that corneal edema. Visual recovery can be quick or it can be very long, up to 6 months. The results at present aren't very consistent. Some people are looking right now at addition of Rho kinase inhibitors. The idea is if you strip the center area where you have symptomatic guttae, the peripheral, more healthy endothelial cells can migrate in and cover that area so that the patients can see better. Rho kinase inhibitors have sort of been shown to sort of help those endothelial cells sort of migrate over, and that's why people are thinking that if we add Rho kinase inhibitors, maybe the visual recovery can recover a little bit quicker. But some, of course, reported issues here, some stromal opacities, haze, and if, of course, it doesn't work, then we can always go back to doing a DSEC or a DMEC. So our next case, we're going to talk about pterygium. And this can significantly contribute to astigmatism and affect the vision. And in topography, typically we see flattening in the area of pterygium and steepening in the vertical axis. In patients that come in with both cataracts and pterygium, we really need to consider whether or not we need to do a pterygium removal prior to cataract surgery. So this is a recent case that came in both with visually significant cataracts and pterygium, and this is a pentacam. And here in the right eye, you can see significant flattening nasally and sort of steepening in that vertical axis that's causing about 10.9 diopters of astigmatism. In the left eye, the pterygium was also nasal, but pretty peripheral. And here, this was not really affecting the vision, causing about 1.5 diopters of astigmatism at 71 degrees. And so the left eye was good to go for cataract surgery, but the right eye really needed a pterygium excision prior to cataract surgery. And this is the same patient. So this is on the left, you sort of see the pre-op where there was almost 10.9 diopters of astigmatism. We did a pterygium excision with a conjunctival autograft. And 3 months later, you could see how regular and nice that cornea looks, now down to 1.7 diopters of astigmatism. And so now the right eye is good to go for cataract surgery as well. So we're moving on to keratoconus. And here, it's really important both to sort of have a high level of suspicion, especially when people don't come in with a formal diagnosis of keratoconus, but also with people that have established diagnosis of keratoconus. So oftentimes when people come in and they have significant asymmetry in their keratometry readings or their Ks, we get a lens star and their Ks are greater than 47, definitely heighten your suspicion and try to get topography or tomography to look at things. In these cases too, when you're trying to figure out, okay, there's a cornea issue, it could be a scar, it could be keratoconus, how much is the cornea affecting the vision over the cataract? And doing a rigid gas permeable lens over refraction will really help sort of tell us is how much the cornea is contributing to how the vision and also how much is related to the cataract. For patients that come in with an established diagnosis of keratoconus, we're looking to see how stable they are. Our veterans come in, they're typically older, so typically they are more stable than people that come in that have that younger patients that come in with keratoconus. And then it's really important to also know, are they long-term RGP users? How well they're using it? Do they like the comfort? Are they toric soft contact lens users? Because that will play into our consideration. Later on, we'll talk about what our lens choices, monofocal versus toric IOL with these patients. Some people will say you never use a toric IOL if it's not a regular corneal astigmatism, but especially for cases where they would never want to wear contact lenses, toric IOLs may be a good option for them. And then during the exam, of course, we're looking for Fuchs striae, thinning, typically inferior, enterostromal haze, scar, prior decimate tears, apical SPK, and Fleischer ring. And so I just wanted to present this case that came in recently to see us. And so this patient was complaining of significant decline in his vision in the left eye, more in the right eye, for many, many years. And he hasn't really seen anybody for a long time. And so when he came in, his vision in the right eye, 20/40, glares to light perception with about +2 sphere. And in the left eye, he was count fingers vision, glares to light perception, again with +2 sphere, wasn't really using any glasses. We did a laser interferometry to make sure we sort of knew that he had some visual potential, 20/30 in the right, 20/60 in the left. And during his slit lamp exam, we see just a few gouttes, no real significant keratoconus changes in the right eye, but in the left eye, there is this very small hint of this mild cone shape, very mild inferior thinning, but not yet Fuchs striae or haze or Fleischer ring. And then in terms of the lens choice, he had 2+ NS with 2+ anterior cortical spoking in the right eye, 2+ NS, more anterior cortical spoking, and really a dense plaque 4+ PSC in the left eye. So the patient really couldn't see out of the left eye with a very dense cataract. And so this is a lens dart, the optic biometer. And here, what's really interesting, one is you look at the axial length, he's a little bit longer in the left eye. And when you look at the keratometry readings, the right eye, 41.4, 41.9, not too bad, right, 0.5. But in the left eye, it's like almost 7 diopters of astigmatism with very steep Ks. And so this is sort of like an indicator that, something is really, really odd here. And so we got tomography. And here's pentacam of the right eye. Again, the Ks are not too bad, 41, 42. You're looking at the thinnest location of pachymetry, that's 534. And then the K max here, let's find it here, 44.7. And so here what's really interesting is you can see that yellow area inferiorly where it's a little bit steep. And the one that says corneal thickness, you can see the pachymetry, that round circle is right in the area of where it's thin here. And then here in the left eye with that significant amount of astigmatism, here you can see almost 6.6 diopters of corneal astigmatism. K readings are pretty high, 43, 40, almost 50. K max on this side is 53, and the thinnest location a little bit thinner than the right eye, 508. And here again, you see the sort of inferior sort of central steepening and thinning in the same area. And so the next one that I'm going to show you to sort of rule in keratoconus is this Bellin-Ambrosio ectasia map. And here in the right eye, you sort of see the bullseye, and the left eye, you really see that bullseye in that bottom image there. And that really rules in that this patient has keratoconus that he never knew about and that we just picked up during his cataract eval. And so what's really important for him, this patient in particular, was discussion with him about whether or not he wanted to consider wearing contact lens after. And he really had no interest in wearing contact lenses or trying contact lenses. And what's really interesting is, nobody picked it up when they did the refraction because he couldn't see to do a good refraction. And so for him, we actually decided on proceeding with a toric IOL in his left eye and then just a sort of monofocal lens in the right eye. But keratoconus in general, if they're a happy RGP users and want to continue to use them, the best thing for them is just to use a monofocal lens, but we're actually going to aim near so that they can actually see the contact lens to put it in after. And then again, we do consider toric IOLs in some cases only if the patient does not want to wear contact lenses and of course the keratoconus is stable. So of course, a lot of our patients come in and they've had refractive surgery, LASIK, PRK, RK. For these patients, it's really important to know the pre-refractive surgery Manifest refraction, were they hyperopic, were they myopic, was this for astigmatism? LASIK, of course, what we're looking for in particular, is it a large, is it a small flap, does it have flap striae, is there any interface haze, where is the hinge? And for RK patients, we're documenting number of RK incisions. I've seen anywhere from 4 to 8 to 16 incisions. Typically, some of them are paired with AK, so it's important to sort of document where those are. Important to talk with the patient risk, during cataract surgery of perforation of the RK incisions, prolonged visual recovery with initial hyperopic shift. And these patients won't be ready for their refraction in 1 month like typical patients are, but probably at the month 2 and month 3 is when they would be ready for refraction. And all of these patients require some kind of topography or tomography for additional sort of measurements we need for the IOL refractive calculators that are specialty ones that we use for patients that have refractive surgery to, again, avoid that hyperopic surprise. This is a case that I saw recently where this patient came in with decreased vision and glare. Mostly he's complaining about the right eye. And so he had a history of RK with touch-up in the right eye, previously fitted with RGP but unable to wear. So his manifest refraction, right eye plus 225, minus 225 at 173. He still had pretty decent vision but significant glare. And in the left eye, very minimal astigmatism correction. And again, vision is pretty good with a little bit of glare. On exam, he had 6 cut RK with 2 AK incisions. What's really interesting about his exam is that the temporal AK incision was significantly gaped with some pooling of the fluorescein. And in the left eye, he had a sort of a standard 8 cut RK, but with 4 smaller incisions, AK incisions. And his cataract surgery exam, his lens was actually fairly mild, trace NS with trace cortical changes in both eyes. So fairly symmetric cataracts, but significant symptomatic glare in the right eye. So in this patient, we did a pentacam. And here in the right eye, which is the eye that he's complaining more, you can see that there's about 7.5 diopters of astigmatism in the vertical axis. And in the left eye, you can see it's much more less. It's 0.4, and the cornea looks much more regular here. Of course, significant flattening centrally from the RK incisions, but this right eye is the eye that had an issue. And so had I gone and done cataract surgery on him in the right eye, he probably wouldn't be happy because his issue here is his cornea. So what we ended up sort of offering him was actually an AK revision. And so to sort of like pull that AK incision closer together. And so we did that for him. And really important to discuss with these patients is that their vision actually is really, really, really terrible after the procedure, because what we're trying to do is pull those incisions together with sutures. Those sutures have to be pretty tight to prevent the wound from gaping out again. So we're talking about count fingers vision after this procedure. And we keep those sutures in for, a couple of months before we even consider removing a few of them at a time. And so this is what we did for this patient. And he had to be very patient with us. And so again, he started out with 7.5 diopters of astigmatism at 98 degrees. We did the AK revision. And this is about 5-6 months after. You can see we really cut it down by half. And his cornea is more regular, and his vision is now, he's really happy with it and correctable in glasses. And so the answer for him was not cataract surgery, but an AK revision. And so just sort of rule of thumb for contact lens use is for soft contact lens users and contact lenses in general, they sort of affect the curvature of the cornea. So soft contact lens users, we say out of contact lenses for at least 2 weeks prior to cataract surgery or IOL calculations. For hard contact lens users, we say for about 4 weeks. Of course, if they're like, decades long wearer of RGPs, we might have them out for a little bit longer so the cornea can bounce back to a more baseline level, so we can again hone in that keratometry reading for the IOL calcs. That's just a rule of thumb. And that's all I have for you. So I am going to pass the baton to Dr. Kapadia to talk to you about glaucoma.
And please feel free to keep asking questions. Dr. Kapadia is going to take our next talk on vision care for veterans. Thank you, Dr. Kapadia.
Great. Thank you, everyone, and a very good evening to you all. I'm going to take the tail end of this talk, Vision Care for Veterans today. And it's, I'm the residency program director for University Hospitals in Cleveland, Ohio, but I also work with Dr. Ron Cohn and Churn at the Louis Stokes VA Medical Center. This is the third largest medical center in the country, and it's our honor and privilege to serve and take care of the veterans and those who serve our country. So with that, I'm going to talk about how glaucoma affects this veteran population and the microinvasive glaucoma surgery that we offer these patients at the Cleveland VA. So as Dr. Ron Cohn mentioned, the Veterans Health Administration is the largest integrated healthcare system, providing care to about 9 million veterans at 1,200 plus facilities and 170 medical centers. It also provides training to greater than 65% of the U.S. trained physicians. And so at University Hospitals, we have 18 residents, and they rotate through the VA where we teach them ophthalmology. Out of these 9 million veterans, 1.5 of them have vision-threatening eye diseases, including 285,000 with glaucoma. And as we all know, African Americans and Hispanics have a high percentage of glaucoma as compared to the Caucasians, and causing blindness. So this was a study that was conducted and published in 2013, but even though it's a decade old, the findings still hold true. And what they studied was the retrospective analysis of the type of population and the diseases that were seen in the veterans from 2007 to 2011. And as Dr. Ron Cohn had mentioned, most of these are 80%, that's a typo there. They are males. The average age is 60 years at that time, and in the past decade has now gone up. There's a high proportion of African Americans, and the prevalence of ocular diagnoses increased from 20 to 23% at that time. Prevalence of cataract increased by 35%, and the prevalence of glaucoma increased by 9.4%. So it was a problem then, and it is also the main diagnosis that we see in our patients as of now. This other study published in the Military Medicine, what they did was they studied patients who presented to the Atlanta VA in 2008, and these patients were just coming in for a regular eye exam or called routine exam. And as they reviewed 658 charts for a period of 2 months, they found that patients, at least 64% of them, had at least one ocular diagnosis other than refractive error. And 25% of them were diagnosed with either glaucoma or were suspects, and they also had cataracts and macular degeneration. So as you see these patients in your practice, it is very important to understand and realize that they may come for a routine exam, but the prevalence of having these other diseases is equally high in these patients. Now, this was a study that was conducted amongst the 86 academically affiliated VA medical centers. The ophthalmology chiefs were asked to fill out a survey to see what these patients that came to the VA center, what was the barrier for access, and also what was the main reason that they presented when they presented led them to have surgery. And so of the 45% responders, most of them believed that non-compliance was the main issue for these patients to undergo some kind of a surgical procedure. Most commonly indicated was the laser trabeculoplasty, but they were also more likely to have tube shunts or MIGS or TRABs. And they concluded, or the survey concluded, that the main reason, again, was non-compliance and access to care in this veteran population. And they showed in their study that these veterans are a complex cohort of patients. They have a higher burden of illness, they have more chronic pain, more substance abuse disorders, and as Dr. Ron Cohn mentioned, mental illnesses. And mental illness is correlated with severity of ophthalmologic disease, especially glaucoma. They also are non-compliant because they have a hard time placing their drops. They're not clear about their instructions. The print is very small for them to read. The other challenges they face for getting care is transportation. Many of these, as many as 1/3 of the veterans, live in the rural communities. And so they have to rely on their friends, their family members to bring them to their doctor visits. And sometimes it just doesn't pan out. And we see all the time that patients miss their appointments and are not able to follow through on treatment. So this is a real problem, and they are more likely to seek out care in their community if they have private insurances, just because it's hard for them to reach these medical centers, which are far away. And therefore, in the Veterans Administration system, the challenges of non-compliance and access to care are mainly responsible for causing advanced diseases in this patient. So when they present to us, they are quite late in the stage of glaucoma. And so with this, I just wanted to present this data to show that glaucoma and cataracts, again, are problems. And if we can help these patients in any way, that would serve them very well. And so one of the things that we help or would be useful for these patients is the mixed procedures. And again, because it has a good safety profile, and considering the issue of non-compliance and cataract in these patients, it becomes a good option for this veteran population. So I wanted to talk about overview of the MIGS. There are two types of MIGS, the implantable MIGS and the non-implantable MIGS. The main mechanism of action by which the implanted MIGS work are by increasing the trabecular outflow, by targeting the suprachoroidal space, and then by a subconjunctival pathway. In the first category, we have the iStent by Glaukos and the Hydrus by iVentis. The Glaukos was first approved in 2012, and since then there have been a couple reiterations of those, and they allowed the fluid to flow from the anterior chamber into the Schlemm's canal, as shown over here. The Hydrus microstent is an 8mm device, again placed in the Schlemm's canal, which was approved in 2018. The CyPass microstent was approved in 2012, where it was used to drain the fluid in the suprachoroidal space, but then recalled in 2018 as the 5-year data of these patients showed that there was a lot of endothelial loss. And finally, the Zen gel stent, which diverts the fluid via this collagen device into the subconjunctival space. This was approved by the FDA in 2016. Now, if we look at the non-implantable devices, these are the different ways by which the outflow can be improved. The trabectome, which is an electrocautery that is used to ablate the trabecular meshwork and the inner wall of the Schlemm's canal, which then allows access to the aqueous humor into the collector channels. This is the trabectome. The Cahoop dual blade is again a disposable device. It has 2 parallel braids that strip the trabecular meshwork. This was launched in 2015. The GAT, or the gonioscopy assisted transluminal trabeculotomy, where a 1mm incision is made, and with the help of devices like a microcatheter, a 5-O-proline suture, as shown over here in the bottom panel, and a TRAP 360 handpiece, the Schlemm's canal is cannulated by these devices, and then the meshwork is unroofed, which then allows good flow of the aqueous humor. The other 2 ways are the ab internal canaloplasty, where a viscoelastic is injected into the Schlemm's canal, either by the microcatheter or this visco 360 handpiece, and then viscodilated. And finally, the ECP, where a section of the ciliary epithelium under endoscopic visualization is ablated, and that decreases the aqueous production. So this is broadly the devices that are available in the market, and many keep coming every few months because this is the way glaucoma is headed. Now, at the VA, what we have as an option for our patients is the iStent Inject W and the Hydrus device, and we teach our residents these procedures. The original iStent was released in 2012, but the latest reiteration was in 2019. It is a arrow-shaped device, has a head which sits in the Schlemm's canal, a flange that resides in the anterior chamber, and then the thorax, which is in the TM. Now, the W device has a wider flange, so it's easier to use it or see it during the surgery. The lumen is 80 microns, and it allows the fluid to go into the Schlemm's canal through 4 holes. Each of these are 50 microns. These are outlets. And 2 devices are implanted about 3 clock hours apart in the intranasal quadrant. And this is how it allows for a large area of the TM to be covered. It is also the smallest medical device known to the human body. It's safe for MRI, and it's heparin coated to promote flow. I'm not going to go into the details of the study, but basically this was the study for iStent inject, which showed that patients who had phaco and an iStent inject had a better reduction in the intraocular pressure as compared to those who had phaco alone, and this was seen at 24 months after surgery. Next comes the Hydrus microstent, which is an 8 millimeter long device. It has an inlet and 3 windows. So you would put the device so that part of this inlet and up to the windows is seen. The way it works is by 3 mechanisms of action. It maximizes the flow through the inlet structure, creates a scaffold in the Schlemm's canal, and enhances the outflow. Again, the Horizon trial, which was instrumental in bringing this device to the market, showed that patients who had the Hydrus stent along with the cataract surgery or phaco had a greater reduction in their pressure as compared to cataract surgery alone. So what points should we consider when we are seeing these patients with who are candidates? One, they should have mild to moderate glaucoma. Of course, they should have associated cataract. They should be on 1 to 2 glaucoma medications. And before surgery, they should all have a conioscopy, so we know that their angles are open and it's possible to do the implant after the cataract surgery. Overall, it's a safe procedure. It's very important once, because of co-management, many of these patients are seen by the community doctors, and it's very important that a gonio again be done after the surgery so that a proper placement is assessed at that time. The few complications that we see, it's again safe, but there could be fluctuations in the IOP initially just because of the retained viscoelastic or hyphema. Sometimes the malposition of the stent can happen, or it could be obstructed. And if there is hyphema, it usually resolves in a week. And you treat each condition as the situation calls for it, with steroids, glaucoma, or cycloplegic agents. And there should also always be a low threshold to send the patient back to the surgeon. As compared to the iStent, the Hydrus has a little higher rate of complications with hyphema. Sometimes it can cause IOP spikes, causes focal anterior synechiae, and cyclodialysis cleft, uretodialysis. And when you do the gonio again in this patient, you see the inlet and a little bit of the stent. Everything else should be behind the TM. This is called a good placement of the Hydrus stent. So the question is, when would you stop glaucoma drops in these patients? Again, for the first month, the drops should be continued along with their postoperative medications. And then 1 drop should be stopped at a time. Follow up and see where their pressure is. If they're a target, then you can take off the medications. New baseline should be established with OCT and visual field. So in conclusion, cataract and glaucoma are common in the veteran population. Issues with compliance, availability of care, and other comorbidities are important considerations in this population. Consider mix for these veterans that need cataract surgery to address these compliance issues. And because of its low rate of complications, safe profile, and easy management post-operative, they are very good indications for our options for these veterans. So with that, I would like to thank you all for giving me the chance to talk about mix today. And on behalf of our team at the VA Medical Center in Cleveland, I'd like to thank you all.
Thank you, Dr. Kapadia. That was really great. And thank you for the speakers for the program. So we have a live Q&A now, and we're going to take some questions. But before we do that, I'd like to have Dr. Evelyn Lewis come and talk about our organization for a moment on the health and wellness of our veteran patients. Dr. Lewis, would you like to tell us a little bit about your organization?
Yes, thank you very much for the opportunity to speak just a little bit about the foundation. In regard to what we do, we are a nonprofit 501(c) charitable entity. We were established by a group of veterans who are very knowledgeable with a lot of expertise in the area of health, wellness, and healthcare delivery in particular, and where those things intersect with social determinants of health and military culture. And one of the things that we exist for is to for the express purpose, if you will, of addressing systemic inequities regarding the access to excellence in care, whether that's provided by the Department of Defense, Veterans Health Administration, or civilian healthcare facilities to veterans and their families. And so if you go to our site, you can get a lot more extensive information regarding our mission and vision. But we really like to put forth so that people understand through our strategic process, we look to approach our mission with the required passion and purpose and commitment, such that we end up with the goal of creating a world where all veterans and their families can live healthy and well lives that are undiminished by the service related health issues, that one of which we were talking about tonight, and those are visual concerns. And so on behalf of the veterans and the families that we serve, I want to thank my colleagues tonight for taking the time to provide these presentations on the various eye injuries, illnesses, diseases, et cetera, that impact veterans. And hopefully those who are listening will come away with understanding the real need here is to be sure to ask that question. Are you a veteran? Have you served in the military? Those questions, because they give you the very first and most critical tool to apply some of the things that you've learned tonight. Once you know they're a veteran, then you know to look for certain things or to ask certain questions. And those then provide them true extended opportunities for the best health outcomes. So thank you all again. And if you have any questions about the foundation after you ask about the lectures tonight, I'd be happy to address those.
That's great, Dr. Lewis. And for those watching, if you want to go to the website, it's myvhwf.org for the Veterans Health and Wellness Foundation to learn more about this wonderful organization.
Thank you.
Let's talk about some of the questions from the audience tonight. I wrote an engaged group of individuals watching tonight. Start off with Dr. Mansavi Kapadia. They're asking questions about the eye stent and the control of IOP. How reliable is the control? Is it really titratable, or is this just you put one in, it doesn't work, you put another one in, it works too well? Like how do we figure that part out of these eye stents at this point?
So we have transitioned from putting one eye stent to commonly now the two eye stents. And so we don't have the option of just putting the one. Most patients are in the past year have all gotten the eye stent inject, which are two eye stents. And so, these eye stents will help to control the pressures even when they're not using the drops. And as I just, mentioned in my talk, compliance is a big issue with these patients. So it's kind of a suspender and a belt kind of thing where even if they miss a drop here and there, they would still have, the eye stent. So most of our patients continue to be on drops for a while, and slowly over time, we try to take them away, but sometimes they just still end up with the drops. But at least we know that they have, better control.
Yeah, and you mentioned the compliance issue, which I was very intrigued by. What is the mechanism, or what maybe any of the panelists can talk about some of the mechanisms to improve compliance with these visits and the regimen you're prescribing? Is there particular tactics the VA has taken that you found have been successful?
So for glaucoma, I can say that we have a sheet of paper with color-coded bottles. And when we see the patients, we ask, we write it out for them and we show them, because most of the patients, and as everybody who is treating glaucoma patients know, that it's basically by the colored top that they know these drop bottles. And so we give them this sheet and they try to, rewrite it out on them. The other thing I like to personally do with my patients is show them their OCT, show them their visual field, because unless they know what they're dealing with, they don't understand the gravity of the situation, and they want to, once they see the field, they're like, oh my God, this is what I'm really having, because again, there's no symptoms. So that is another thing that helps with compliance. And I think thirdly, the teach back technique is very important, where instead of you telling them, okay, use this drop twice a day or at bedtime, you ask them to see if they really understood what you're trying to tell them. So I think that has improved the compliance quite a bit in our patients, at least. Or we try.
Great. That's great.
Another thing I'd like to add is it's really important to find out from the patient, what helps them remember to use their drops, or what are their barriers to using the drops. Sometimes it's as simple as, I can't get the drop in, and we have different devices that we can help them. Is it because they have rheumatoid arthritis, they have trouble squeezing the bottle? Is it because they have a hard time centering the bottle? I know that typically for PGAs like latanoprost, we tell them to use at bedtime, but if they fall asleep and don't use it at bedtime, that doesn't help. And so asking them to maybe use it in the morning, again, is just figuring out sort of what barriers they have and trying to overcome them. Of course, other options like doing SLT is going to be helpful. And then, of course, utilizing the combination eye drops that we have, is also going to be very helpful.
Mm-hmm. Dr. Chung, they were asking questions about cross-linking in cataract surgery. How much does cross-linking affect the K values, and how do we account for that when we discuss cataract surgery? Is it something we have to do after cataract surgery only, or do we do it preoperatively? How does that work?
I mean, we know that cross-linking can flatten the case. And so that, I'm assuming we would only consider this if the patient has progressive keratoconus that you're trying to stabilize. And I would make sure that everything is stable before we go into cataract surgery, unless there's a big need to. Hopefully, by the time that they need cataract surgery, they typically are older and more stable. They probably won't need cross-linking. But if you're talking about the younger folks, definitely try to get their cornea stabilized before you do cataract surgery would be the best way.
Mm-hmm. And you presented another case on dry eye, and I can't help to think about how many patients go through that and have that minor shift in the K values, which have major shifts in the IOL selection. How does one figure out, and maybe Dr. Roncone too, if you can comment just on what K value or what tips you off to tell you that's enough dry eye to give you a potential shift? Because looking at that patient's history, I probably wouldn't have assessed it myself. I think only prior to surgery. So I'm glad you're able to pick that up in that patient.
Yeah. So for us, when we're sort of looking at everything, one, of course, looking at the eye, looking to see what level of dry eye they are. And then, if things don't make sense when we're looking at the sheets, especially when there's asymmetric K values from one eye to another, and we're looking, when we're looking at cataract surgery in both eyes, I'm looking at implant choices for both eyes too. Why is one so different than the other? Of course, if someone has significant SPK staining, in addition to other things, I'm always going to optimize them first, bring them back, and do another sort of optical biometry just to make sure that we are, on the right track. And if it's consistent, fine. And then especially if they have asymmetric values, I'm going to have them optimize and come back just to make sure that, that we're sort of on the right track for that patient.
Yeah, that's great. There was a question from one of the audience members about any recommendations how to engage your local VA regarding ophthalmology needs for your vets in your area. How do the patients get plugged in? Is there any particular advice you'd give this individual?
Dave, did you want to take that, or did you want me to chat a little bit about it?
I'll let you take it.
Okay. So I would say that it's really important just to know which VAs are around your area and sort of engage and talk to the people there. Each VA offers different things and have different sort of doctors there, and everybody does it differently. I wouldn't say that every VA is the same. And so definitely sort of finding out your closest sort of VA and see what kind of services they provide there would be really, really helpful.
Dr. Roncone, you mentioned tea tree oil products on the formulary of the VA. Somebody asked about what product that was. And also the Avenova. Is that on formulary at the VA? And because this individual doesn't have it on formulary at their VA, they're asking that question.
I see. I can take that one. Mm-hmm. So each VA, even though, because I sort of went through the whole process for the tea tree oil or the Clearadex, and so even though the product may be approved at the national VA level, each individual VA has to go through a process through their pharmacy to actually get it onto their local formulary. So if it's something that you feel strongly about, you have to sort of engage your pharmacy to sort of, tell them what the need is, why it's really helpful for our veterans, and sort of advocate for it and sort of get it on the list for you. And so even though it comes on national, it doesn't mean that that's nationwide. You sort of have to, at a local level, sort of push for it. That's it. Clearadex is sort of, and for example, the Bruder mask, because we also have it's a microwavable eye mask that's great for our blepharitis patients. Those are actually really interesting because they're not really a medication. And so those, again, you have to engage pharmacy and prosthetics to sort of help get those into your VA.
And in the same way, we also, the glaucoma drops like Ropressa, Rocklatan, and Vyzulta. Our veterans are lucky to get all these drops. Again, that decreases the drop burden, but we have to go locally through our pharmacy to get that approved and be on non-formulary for our veterans.
Again, all these medications that we're talking about, especially the branded medications, at most VA levels, you sort of have to document that they failed other drops before you can move on in using those branded names. And so it's not that just because it's on formulary that would be the first thing that you choose for all veterans.
Yeah, that's great.
For our scleral lenses, we use Contact Neutrophil, and it was interesting. That type of lens filler for scleral lenses has regenerative properties. And so we wanted to use that over like an Adipac or a Bausch & Lomb lens filler. And when we went through the process, actually with our Cleveland VA, we had to propose it, and it had to go to national first. And then once it was approved as a lens filler by national, now all of the other VAs can follow suit like Cleveland and use Contact as their lens filler. So we were really, really excited with that because all of these veterans who have selflessly served with corneal problems, we really want to maximize their vision and their corneal integrity and ocular surface to the maximum potential that we can. So it was a really exciting thing to be part of.
Yeah, and this is the last question for tonight. I was struck by how much dry eye there was in the VA population compared to the general population, civilian population. There wasn't, I don't remember seeing a reason why. Can you give some thoughts about why dry eye is so prevalent in this group? Is it the age? Is it the race? Is it what is the status of that?
I think it's when we looked over all of the risk factors, I think that has a lot of weight. I think that looking at the metabolic disorders, the diabetes, the smoking, the age risk factor, I think that has a lot to play with it. In the patients with mental health disease, the number of medications they use, even in the patients who don't have mental health issues. We have a high prevalence of hypertension and other diseases that patients are using those systemic meds that induce dryness. So I don't want to point absolutely at just systemic and medications, but when I talk to people, some people say, what common things do you see at the VA? And we always want to say AMD, diabetic ret, but I mean, realistically, we see a lot of dry eye, just as the general population does. And we see a lot of eyelid disease, a lot of blepharitis and meibomian gland dysfunction. And in those multifactorial settings, just like in the general population, MGD plays a huge role in dry eye. So I think that contributes a lot too.
Yeah. Well, I really want to thank all of the panelists for today's program and thank the audience for watching. This has been a wonderful program. Thank you, Dr. Roncone, Dr. Charn, Dr. Capadia, and Dr. Lewis for your participation in today's program. And for those of you watching, please make sure to get your email afterward for the CE and CME credit. And enjoyed having you on the program. And we're going to have an upcoming program on retinal diseases coming up in a few weeks. So please be on the lookout for that retinal program as well in the near-term future. Thanks a lot and good night.
Thank you.
Thank you. Good night.